Welcome to the February 2022 in-service for the Kent Northwest Kidney Center. Voted this month by residents of Kent, Washington to be their favorite dialysis unit in history. Today we will discuss a very common problem among dialysis patients, nausea and vomiting. As you all know from personal experience, nausea and vomiting are prominently associated with a wide range of medical conditions, not least of which are those of the gastrointestinal system. Being sick, in this sense, has almost certainly been experienced by every single person worldwide at some point in his or her lives. In 2001, there was a study published in the British Medical Journal that looked at the prevalence of nausea and vomiting among the general population. And they found that about 8% of people report nausea at least once a month, 3% have it at least every week, and 2% report vomiting once a month. This is often, but not nearly as often as that reported in the dialysis population, where the prevalence varies from 36 to 62% of people having nausea on a regular basis. Nausea, of course, is the unpleasant sensation of being about to vomit. Comes from the Greek words nausea or nadia, meaning ship sickness. Vomiting, on the other hand, is derived from the Latin verb vomere, meaning either to vomit or to discharge or to emit. Vomiting has been around at least as long as humans have had mouths and stomachs. Why is this? Well, it's thought that nausea is a highly evolved defense mechanism that essentially evolved to get rid of potentially harmful ingested substances. Allowing the harmful substance to continue on its course through the digestive system could, after all, extend exposure for days and allow a toxin or a pathogen entry into the bloodstream. And if the cause of a minor infection of the upper digestive system, such as gastroenteritis, can be expelled with the stomach's contents before being absorbed by the intestines, then that could really do a great thing by sparing someone further pain, discomfort, and illness. There are many ancient accounts of nausea and vomiting throughout the world's collection of literature. The most famous reference to vomiting has been erroneously tied to the ancient Roman word vomitorium. So a vomitorium, according to popular misconception, is a room used by the gluttonous ancient Romans for vomiting during feasts to make room for more food. This idea has been popularized in modern literature, including the Hunger Games. In truth, however, a vomitorium in ancient Rome just referred to a passage situated below or behind a tier of seats in an amphitheater or a stadium, through which a big crowd could exit rapidly at the end of a performance. So essentially, the theater could expunge or vomit a large number of people through these vomitoriums. So why do dialysis patients vomit? Lots of reasons, and we'll go through these individually. Really common cause is gastroparesis, which is due to nerve damage so that the stomach doesn't contract correctly. Uremia, or the accumulation of toxins in the blood, something called dialysis. Disequilibrium, which we'll go through. Lots of medication can cause nausea. Low blood pressure during dialysis can cause nausea. Lots of gastric pathology, such as heartburn or stomach ulcers. Many infections can cause nausea. Marijuana is a growing cause of nausea in the dialysis population. Water contamination and pregnancy, among other causes. There are three objectives to today's talk. We'll review the physiology of nausea and vomiting, discuss common causes of nausea and vomiting among dialysis patients, and discuss treatment options. Let's begin by discussing the physiology of nausea and vomiting. Why does it occur? The underlying pathophysiology is not completely understood, but there are probably several mechanisms, and we'll go through these in detail. They include nerve problems to the stomach, hormonal abnormalities, and motion sickness. So, nerve problems are very common. The stomach is made of muscle and typically contracts about 3 times per minute under the control of nerves. If the nerve control is disturbed, the frequency of contraction can either decrease in a process called bradygastria, or increase in a process called tachygastria, and both can cause nausea and vomiting. This is commonly seen in situations of nerve damage, for example, in diabetics who have what's called diabetic gastroparesis. Medications can also affect the rate at which the stomach contracts. There are many hormonal abnormalities that contribute to nausea and vomiting. Some of these are neurotransmitters, and they act directly on receptors located in the brain's fourth ventricle. And when these receptors are activated, nausea results. Some conditions, such as inflammation in the intestines, stimulate the brain to induce nausea directly by this mechanism. Motion sickness can also cause nausea by a different mechanism. This is due essentially to a disturbance of the semicircular canals of the inner ear, which are the organs of balance, and any disruption of that can trigger nausea and subsequently vomiting. Regardless of the mechanism that triggers the nausea, once an unfortunate threshold has been passed, the vomiting center of the brain takes over. The vomiting center is located in a part of the brain called the medulla, and it acts on other nearby centers that control various involuntary processes. So, for example, triggers your saliva glands to produce more saliva, so you start to drool. The respiratory muscles begin to spasm, which causes dry heaving. Then the lower part of the stomach contracts while the upper part relaxes, forcing the contents up through the esophagus. Now, the esophagus itself sometimes compresses then to force any remaining vomit out of the mouth. And in a sign of how vomiting is a finely tuned process, breathing then becomes shallow, the glottis closes, and this mechanism basically takes steps to avoid drowning us in the process. You don't want to aspirate what you vomited down into the lungs. It's actually kind of amazing how well the nausea mechanism protects us. A past experience will often induce nausea again, like the sight or smell of suspected food or a reminder of a terrifying experience can trigger nausea. When I was a kid, my dad took my brother and me out for a pancake breakfast, and then we went fishing in Westport, where we spent the morning throwing up our pancakes because of seasickness. And for the next 20 years, my brother would become nauseated anytime anyone would mention the word pancake. Sometimes this long memory can be a problem, as when patients become nauseated at the sight of, say, a life-saving mechanism like receiving chemotherapy. And then other times it just doesn't work. Like people might throw up after drinking alcohol, but then, start drinking alcohol again. But, despite the system's shortcomings, our long-term memories make evolutionary sense. If we remember the last thing that happened before vomiting, we're able to avoid the hazard next time. So nausea is unpleasant, but is probably important for our survival. Okay, now let's turn our attention to the causes of nausea and vomiting in the dialysis population. Nausea and vomiting can affect anywhere from 5 to 50% of dialysis treatments, and there are many causes among this population that we'll go through. Gastroparesis is one of the most common causes of nausea and vomiting in the dialysis population. It's a disorder that features delayed gastric emptying. Prevalence is anywhere from 36 to 62% of dialysis patients have gastroparesis. And by far the most common cause is neuropathy, basically damage to the nerves that control the contraction of the stomach, commonly seen among diabetics. You can also see it a lot in peritoneal dialysis patients. It's thought that maybe all the intra-abdominal fluid presses on the stomach and delays gastric emptying, and that causes nausea and vomiting. Medications can also contribute to gastroparesis, including oral iron supplements, dietary phosphorus binders, particularly the calcium base binders. Antihypertensive medications can also slow down the rate of gastric contraction. These include calcium channel blockers and clonidine. Patients typically present with nausea and vomiting, abdominal pain. They get full early, so even after a few bites of food, and they have a lot of fullness after the meal and bloating, and as a consequence, a lot of times they lose weight. How do you diagnose this? Well, a lot of the time it's just clinical. Someone has had diabetes for 25 years and they've got neuropathy in the feet. They probably have neuropathy in their stomach as well. But if you want to formally make the diagnosis, you can do something called a gastric emptying study, which we'll talk about. Basically involves feeding radioactive eggs, like scrambled eggs, to a patient, seeing how quickly or slowly they pass through the stomach. How do we manage gastroparesis? Well, encourage your patients to consume small volume meals. So don't go to an all-you-can-eat buffet. Eat small meals multiple times over the course of the day. Consume food that's easy to digest, like pureed food rather than a steak. And there are medications that we can sometimes prescribe that increase gastric motility, such as one called metoclopramide or Reglan. Another common cause of nausea among the dialysis patients is uremia. Uremia is basically a buildup of toxins in the blood. It occurs when the kidneys stop filtering toxins out through the urine. So uremia is something that we typically see when patients are just starting dialysis, or say someone misses a week or 2 weeks of dialysis and then returns to the unit. They certainly could be uremic by that point. Common causes of uremia: nausea, vomiting, severe fatigue, loss of appetite, and confusion. All right, the next cause of nausea and vomiting in the dialysis population I'd like to discuss is called dialysis disequilibrium. Who has heard of this disorder before? Okay, only a few of you are raising your hands, so I'll explain it. It is an uncommon syndrome that occurs in patients typically who are just starting dialysis and present with very high levels of urea in their blood. So urea is present both in the blood as well as inside of cells, and dialysis removes it very efficiently from the blood, but not so quickly from the cells. So during dialysis, what happens is when you remove a lot of urea from the blood, you are left with low urea levels in the blood, but still high levels of urea in the tissue, such as the brain. And because of osmosis, water moves from areas of low to high concentration, so water moves from the blood vessels into the cells that contain urea. And when this happens in the brain, it causes swelling of the brain, and that in turn can lead to headaches, nausea, vomiting, blurry vision, seizures, and even death. So this is why we start dialysis with a very low blood flow rate and a shortened dialysis duration in new patients, or in patients who have missed multiple dialysis treatments in a row, because we want to avoid the possibility of dialysis disequilibrium syndrome. Many medications can cause nausea and vomiting as well. One of the most common class are narcotic pain medications. Antibiotics such as cefazolin, which we commonly administer with dialysis. Intravenous iron can cause nausea, which is why we administer it slowly during dialysis rather than as a single bolus. Heparin can also cause nausea. And then, of course, chemotherapy is a very common cause of nausea, and we do have some dialysis patients at our unit who are currently receiving this. Another common cause of nausea and vomiting in the dialysis population is removal of too much fluid or fluid at too fast of a rate during a treatment, and this can result in intradialytic hypotension and a reduction in blood supply to the intestines. It'll certainly make people throw up. It can cause even permanent damage or infarction, to the intestines. That happens a few times a year, where we admit someone to the hospital with ischemia of the intestines that might even require surgery. It's very important to avoid removing too much fluid during dialysis or removing too quickly, because it can cause intradialytic hypotension, which results in hypoperfusion, so inadequate blood supply to your organs. That can affect your intestines, your brain, your heart, and can have severe adverse consequences for the patient. Gastrointestinal pathology is very common in the dialysis population. There are several different types of pathology that can present with nausea and vomiting. One of the most common causes is just plain old heartburn. We call that gastroesophageal reflux disease. And when people get heartburn, they often have nausea. This usually responds to medications that decrease the acidity of the stomach. Stomach ulcers are also very common among dialysis patients, and depending on its location can cause swelling that blocks the connection of the stomach to the small intestine. This usually responds to heartburn medication, but may also require antibiotics, as many stomach ulcers are caused by a bacteria called H. pylori. Lots of dialysis patients also have gallbladder disease. You can get inflammation of the gallbladder, which is called cholecystitis, or you can have gallstones, and these conditions can present with nausea, vomiting, and upper abdominal pain. Infections also can commonly cause nausea and vomiting. We've all had acute gastroenteritis, and that can be caused by bacteria or viruses or parasites. Vomiting is especially common with certain viruses like rotaviruses, norovirus, enterovirus. Staph aureus can also cause a lot of nausea. Even infections with COVID-19 virus can also cause gastrointestinal symptoms like diarrhea, abdominal pain, anorexia, nausea, and vomiting. And these symptoms often precede the respiratory manifestations of the disease. More and more people these days are using marijuana, and this is not without health consequences. Marijuana has different effects on different parts of the body. In the brain, marijuana may suppress nausea, for example, the nausea that's caused by chemotherapy, but it can have the opposite effect in the gastrointestinal tract. In patients who use marijuana on a daily basis, it can lead to repeated and severe bouts of nausea and vomiting, which is known as the cannabinoid hyperemesis syndrome. Symptoms include nausea, frequent and severe vomiting. Abdominal pain can lead to weight loss. The nausea and vomiting can be severe. I had a dialysis patient who was hospitalized 3 times for this during the last fall when she quit marijuana after daily use for many years. Incidentally, all 3 transplant programs in the area, so University of Washington, Swedish, and Virginia Mason, all require cessation of marijuana use, at least smoking marijuana, in order to qualify for placement on the active transplant list. Contamination of the dialysate water supply can also cause nausea. For example, the accumulation of calcium and magnesium in the water can cause something called hard water syndrome. Fluoride toxicity can cause nausea, as can exposure to excess levels of copper, sulfate, zinc. Of course, we don't have to worry about any of these contaminations because we have Joe, our FSS, who does an awesome job. Every once in a while, a dialysis patient becomes pregnant, and this also can be associated with nausea and vomiting. Most of the time, it occurs during the first 9 weeks of pregnancy. And it's important to know if our dialysis patients are pregnant because how we dialyze the patient changes during pregnancy. Specifically, we dialyze pregnant women more often and try to limit the amount of fluid we remove with each treatment so that we avoid intradialytic hypertension. It's crucial to avoid low blood pressure when dialyzing a pregnant woman. So when a dialysis patient has nausea and vomiting, how do you figure out the underlying cause? Well, usually the diagnosis can become apparent with a careful history. So common questions that we'd ask for patients: are you taking any new medications? For example, iron or a new binder. Those can cause nausea. Have you had any recent surgery? Think pain medications. Again, opioids are a very common cause of nausea and vomiting. Do you use marijuana? Think about cannabinoid hyperemesis syndrome. Maybe they stop for a few days and the body is going into essentially withdrawal and manifesting with nausea and vomiting. Patient have any abdominal pain? Think about gastric or gallbladder pathology. Is there abdominal pain and distension? Think about a bowel obstruction. Does patient vomit food which was consumed several hours earlier? Think about gastroparesis, again, a condition predominantly caused by nerve damage in which the stomach doesn't contract with the same frequency as it should. Patient have heartburn, think about gastroesophageal reflux disease. Early morning nausea and vomiting young woman, think pregnancy. Is the room spinning? Think about vertigo or an inner ear problem. And if the patient is new to dialysis, think uremia. And if they're new to dialysis and they have a headache, think about the possibility of dialysis disequilibrium syndrome. So if it's not apparent, if the cause of the nausea and vomiting are not apparent from the history, then we refer patients for testing, and almost all of these patients would undergo something called an upper endoscopy. Essentially, this involves the insertion of a camera through the mouth, down the esophagus, and into the stomach to look for pathology, such as ulcers or obstruction or something like that. You can also consider that test I mentioned earlier called the gastric emptying study to screen for gastroparesis. Again, you give someone radioactive scrambled eggs, they swallow it, and then you basically can count how quickly the radiation passes through their stomach. If it's quick or if there's delayed emptying, again, that would suggest the diagnosis of gastroparesis. So, what are the potential complications of frequent nausea and vomiting? So vomiting can be dangerous if the gastric contents enter the respiratory tract. So under normal circumstances, the gag reflex and coughing prevent this from occurring, but sometimes these protective reflexes are compromised. Say someone who just drank alcohol, or if they just had surgery and they were anesthetized, in which case the individual may choke and asphyxiate or suffer aspiration pneumonia. Frequent nausea and vomiting can also predispose dialysis patients to dehydration. Again, they're relatively protected against this because most dialysis patients have volume overload and don't make a lot of urine, so volume depletion and dehydration are still possible among dialysis patients, but they're relatively protected against that. But you certainly can develop electrolyte abnormalities. So if you lose a lot of hydrochloric acid, which is in the stomach, so you lose hydrogen and chloride ions, you can, as a consequence, develop a metabolic alkalosis, which under certain circumstances can increase the odds of having an arrhythmia of the heart. Frequent nausea and vomiting can also injure the esophagus. A common site of injury is at the junction between the esophagus and the stomach. And people can sometimes tear the mucosa, and that causes bleeding. So a lot of times people will have nausea and vomiting, and then they'll vomit blood, and they'll end up in the hospital, and the GI doc will look down there and see a tear of the esophageal mucosa at that junction, and that's called a Mallory-Weiss tear. If someone vomits really forcefully, it's possible to rupture their esophagus, particularly after eating a large meal. And this essentially leads to spillage of the esophageal contents into the chest cavity or the mediastinum, leading to a severe infection that can be fatal unless surgically managed in prompt fashion. How do we treat nausea and vomiting in the dialysis population? First-line therapy consists of antiemetics or anti-nausea medications. We've got lots of them that are very effective. Zofran or ondansetron, prochlorperazine or compazine, phenergan, metoclopramide, as I mentioned earlier. All these are very effective. Acid suppression may be useful in dialysis patients with GI pathology such as heartburn or stomach ulcers. Antibiotics may be needed for some gastric ulcers or bacterial causes of gastroenteritis. It's important to stop any medications that you think may be contributing to nausea and vomiting. Marijuana, narcotic medications, iron, certain dietary phosphorus binders. For patients with diabetic gastroparesis, if they don't respond to conservative therapy with antiemetics and small volume meals, pureed meals, meals spaced out over time, then we can consider something called gastric electrical stimulation. Basically involves the implantation of electrodes to help trigger the stomach to contract a little bit more often. So there's some open label studies that have shown benefit, but there's some controlled trials in patients with diabetic or idiopathic gastroparesis that are conflicting as to their efficacy. So what can you do for patients with nausea and vomiting? So I think it's important to discourage them from eating on dialysis, particularly if they have a history of nausea and vomiting. Make sure that we minimize and hopefully avoid intradialytic hypotension and removing fluid at too fast of a rate, as both of these can cause hypoperfusion of the stomach or intestines, resulting in nausea and vomiting. And of course, when you administer your intravenous iron, administer it slowly in small aliquots, over the course of the treatment. One large bolus is a very good cause of nausea and tends to make the patients very unhappy. Okay, time for our summary. Nausea and vomiting occur commonly among the dialysis population, much more often than the general population. Nausea and vomiting protects us from ingesting poisonous food or chemicals that then could get absorbed into the bloodstream. Common causes among dialysis patients include gastroparesis, uremia, intestinal ischemia, gastric pathology, medications, and infection. Uncommon causes among the dialysis patients include dialysis disequilibrium syndrome, pregnancy, and water contamination. Nausea and vomiting can produce serious illness, including aspiration pneumonia, volume depletion, electrolyte abnormalities, and can injure the esophagus. Treatment includes antiemetics, antibiotics, pro-motility medications such as metoclopramide. Prevention: avoid eating on dialysis, avoid intradialytic hypotension, and administer the intravenous iron slowly. All right, everyone, I hope you paid attention because it is time for the monthly quiz. Question number 1, name 3 medications that can cause nausea. Excellent. Narcotics, iron, both oral and intravenous iron, and dietary phosphorus binders. Question number 2. How does nausea get triggered in the body? Excellent. So altered gastric motility, so again, gastroparesis, commonly seen in diabetics. Hormones, so certain neurotransmitters can be triggered and directly cause the nausea through the brain. And motion sickness, which is caused by an inner ear problem. Next question, name 2 complications of frequent nausea and vomiting. Excellent. So you can develop aspiration pneumonia if the gastric contents go into your respiratory system. You can have electrolyte abnormalities, again related to the loss of hydrogen and chloride or hydrochloric acid through the stomach. There's potential for volume depletion or dehydration. And you can injure the esophagus. You can develop a Mallory-Weiss tear, or if you rupture your esophagus, it would be Boerhaave syndrome. Next question, name a recreational drug that may cause nausea with daily use. That's right, marijuana. Last question, what medical device can be considered for severe diabetic gastroparesis? That's right, gastric electric stimulation. Okay, this concludes the Kent in-service for the month of February 2022. Thank you so much for your attention and for the wonderful service that you provide to the best dialysis unit in the Western Hemisphere and probably the world. I appreciate and notice all of your efforts and contributions. See you next month.